Hello, dear colleagues and friends. It's Conversations About Hearing. My name is Gazisto Fatulin, and our today's topic is auditory brainstem implantation. Let me introduce our guest, Professor Ranjith Rajeswaran, Director of MERF-Institute of Speech and Hearing, Chennai, India, Chief Audiologist at Madras ENT Research Foundation, founder of Hearing for Life Foundation. He is one of the founder members of Cochlear Implant Group of India and Hearing, expert core committee member of Rehabilitation Council of India, executive committee member at Anna University, president of Indian Speech and Hearing Association. He is the first in India introduced auditory steady-state responses in 2002, and he is the first in India performed electrically evoked auditory brainstem response for cochlear implants. Also, he is the first audiologist in India and Southeast Asia to perform auditory brainstem implant to restore hearing in children with absent inner ear and auditory nerve. He introduced the first formal training for auditory habilitationists in India. Professor Rajeswaran, thank you for being with us today.
Good morning, Gazis. Thank you so much for inviting me. It's been a great pleasure and honor to give this interview to you specifically.
Could you please shortly describe audiology in India and a few words about the MERF-Institute?
Okay. Now, audiology in India was initiated in the year 1968-69, so it's quite old. The way the field has evolved over a period of time is very interesting. So initially, we had an undergraduate program in audiology and speech-language pathology. And this has been a 3-year undergrad program. Later, after 5 years from the day of the inception of the program, they also introduced masters in audiology and speech-language pathology. We never had a single specialty degree. It is always a combined honors degree of both audiology and speech-language pathology together. Now, this has been going on, and a lot of institutions have started this program. And in the year 2000, the undergrad program in audiology and speech-language pathology is been changed from 3-year program to a 4-year program. And in the year 2018 or 19, I would say the masters has been bifurcated from audiology and speech-language pathology to masters in audiology and masters in speech-language pathology. It's been specialized. So this is the evolution of the program in India. But the field of audiology is quite popular in India. And though the number of audiologists who are available is still very insufficient to cater to the population of the country, the field has been existing for several years in this country. And to mention about the MERF-Institute of Speech and Hearing, its MERF is an expansion, is an abbreviation of Madras ENT Research Foundation, which was established in the year 1996. Now, when we established this institute, institute, one of the important goals is to cater to all segment of people with all latest technology, with the cutting edge technology infrastructure, where we would be able to provide all sorts of treatment related to communication disorders, otology. So complete ENT surgery, complete audiology, complete speech-language pathology. Then we did our first cochlear implant in 1997 with 2 adults. The founder of the MERF is Professor Dr. Mohan Kameshwaran. He is one of the greatest figures in otology in this part of the world. And he was also been awarded for his service by the highest civilian honor by the government of India. We did our first brainstem implant in the year 2004. When we did the first brainstem implant, we understood something very, very important. The most important professionals in the field of hearing implants, because the future is going to be hearing implants. Because if you look at the candidacy for implants over the years has been changing. And it's been more and more candidates needs an implant with the present indications what we have today. So the future is hearing implants. But the audiologists, those who have training in hearing implants is very, very minimal, even if there are a lot of institutions. But there are not many institutions, very, very 1 or 2 institutions which has some clinical work and hearing implants. So now these professionals are at need. So this put us a lot of importance that we wanted to start our own institute where we offer undergrad program in audiology, speech language pathology. We offer postgraduate program in audiology, speech language pathology. We offer doctorate program in audiology, speech language pathology. We also created new programs for training the speech therapists and also the teachers for the deaf, a program called the Postgraduate Diploma in Auditory Amputation, where these people are trained to treat children with cochlear implants or some form of residual hearing or with some form of residual hearing. So this is very important because these are the children those who are born completely deaf, and over a period of time, they've been restored with normal hearing, either with an implant, or a middle ear implant, or a cochlear implant, or a hearing aid, whatever. But the way we train those children has to be totally different from the way we train children with hearing impairment. So we developed a formal training program, which is a 1-year program, which is also accredited by the council. So we offer all these courses. We also offer courses for post-doctoral fellowship in implantation pathology. We're going to start a course on master's fellowship in implantation audiology as well. So this has been our journey. And we have at any point of time 200 students studying with us in audiology, speech language pathology. We have people from all over the world coming over here. And we started our program in 2006, and we're almost now 16, 17 years old now in this program.
Ranjit, I know about your great experience with auditory brainstem implant. How it became possible in India? What did you start from?
Well, I want to make an important quote here. This is something which I realized over a period of time. This is very important, which I've learned. There is no science without politics. It's very, very important. And the way we started brainstem implant is very interesting. Now, myself and Professor Dr. Mohan Kameshwaran has a very similar thought in many ways. In fact, he is my mentor, and I've learned everything from him. And one of the important things is everything that we do has to reach to the last man, even to the commonest person in the country. That is number one. And there should be nothing in this world that we will not be able to do for our people. These are the two things. Whatever is the latest technology, whatever is the latest procedure available, we should bring it to our table to cater to the people. This is number one. Now, we've been doing a lot of cochlear implants, but we also encounter a lot of patients who will not be benefiting with cochlear implants. One such patient was a 14-year-old girl who has been diagnosed with neurofibromatosis type 2, where when they remove the tumor in the eighth nerve has been damaged, and she lost hearing on both sides. So she's a very promising, bright girl, and the only option for her would be a brainstem implant. So when we wanted to do a brainstem implant, it was quite a challenge. We will not be able to source the implant because there are a lot of conditions made by the manufacturers to us before we start an implant. So one of the conditions was the audiologist should have done enough number of EABRs before we do a brainstem implant. That was one of the important conditions right now. But at that point of time, I'm talking in 2003, 2004. At that point of time, we have never heard of an EABR, and nobody in the country had an EABR. And we don't know where to buy this equipment. Finally, we sourced a company which was selling EABR, and we contacted them. They delivered the machine. But at the end of the day, they don't know how to install the machine. They don't know how to run this program for us. So everything I learned it step by step by myself. Then we did EABR, and we could do EABR on many children. Then we proved, yes, we are able to do EABR, we can record responses. And then the implant was shipped to us. We did the first implant. When we did the first brainstem implant, it was completely funded by ourselves. So we spent a lot of money from our side to show the world that this implant works. Similarly, when we did the cochlear implant, to show the world that cochlear implant works, it was completely funded by ourselves. We spent money from our pocket to show the world that cochlear implant works. So when we did the first brainstem implant, it was a very, very successful child because after the implant, the child went back to school, finished her schooling, finished her graduation, she finished her post-graduation, she was working, she was doing extremely well. So that was the biggest success. So my message is, if at all you wanted to do something, select a good candidate. The candidate has to be very good so that the outcomes are much better. It is very, very important to show good outcomes when you start a first procedure. Only then you will be able, more and more people will start believing in the procedure. That is very important. Your first results are bad, then it's very difficult for you to convince more people to, enroll into the program on it. So this is one important message that I wanted to convey today. But it was not easy. We went through a lot of challenges over a period of time before we start the brainstem implant. But the reason for us to start is nobody in the country or nobody in the society should be denied of getting a treatment or a procedure just because it is not available. So it is the duty of the professionals to make sure it is available to the people. That is very important. Affordability, accessibility all comes secondary, but availability has to be there first before we can move to the next thing. And in 2009, we did the first brainstem implant on a child. That was the first pediatric brainstem implant. And since then, there is no looking back. So we have done more than 85 brainstem implants for children as of now. So since 2009. But starting was a big challenge because convincing the family to believe. You also need a very good patient to start. But that was not easy. But we had a vision, we had a ambition to do it, we had the drive to do it, we could do it.
From your point of view, which are the main differences between CI and ABI in general?
Okay, now there are two things to it. Number one, in terms of device and also in terms of the function. In terms of the device, the cochlear implant and brainstem implant is 99% is similar, except for its design of the electrode and the placement of the electrode. In a cochlear implant, there is an electrode array which is inserted into the cochlea. And you are pretty sure it goes into the cochlea because there are a lot of anatomical landmarks for the surgeon to push it into the cochlea. And there are a lot of simple verification methods to prove or to validate the electrode is inside the cochlea. But in a brainstem implant, it is more challenging because the electrode is the electrode paddle and the electrode has to be placed in the cochlear nucleus in the brainstem, which is bypassing the cochlea and the cochlear nerve. Now, the anatomical landmarks to locate the cochlear nucleus is not there. We don't have any strong anatomical landmarks. And remember, the anatomy is anomalous. There's an anomalous anatomy. That is why they go for a brainstem implant. So placing an electrode is different compared to cochlear implant and the brainstem implant. The electrode design is different. The second part is the function. The way the cochlea functions, the way the cochlear spiral ganglion cells codes electrical signals is different from the way the cells in the cochlear nucleus codes. Because in a cochlear implant, you can stimulate the entire cochlea. For example, the device called the longer electrodes. Medal has got a lot of different size of length of electrodes. You can use a longer electrode to stimulate the entire cochlea, which is very, very good. Which is in principle, it's the best. So, but it will stimulate the entire cochlea. However, it is not possible in cochlear nucleus when you do a brainstem implant. The cochlear nucleus is a spherical structure. When you put a brainstem implant, electrode is a small surface. It only touches the surface of the cochlear nucleus. It doesn't stimulate the entire cochlear nucleus. So, and also the function of the cochlear nucleus is totally different from the function of the cochlea by itself. So these are the differences. One is technical, that is device-related differences, and the function-related differences. These are the two major differences between a cochlear implant and a brainstem implant. And of course, the etiologies and the indications are different. Why do for a cochlear implant and a brainstem implant?
Ranjit, I'm not going to ask you about the definite indications for ABI. It's quite clear, but let's talk about the uncertain cases. For example, when the patient has normal or even abnormal cochlea, but we are not sure about the existence of auditory nerve based on computerized tomography or MRI. Which additional methods we should use and which strategy do you recommend in these cases?
Okay, it's a very, very interesting question. We call these patients called the gray zone candidates. So we really don't know where they belong, whether to go for a cochlear implant or a brainstem implant. Yeah, definite indicators, you're absolutely fine. When there is no cochlea, when there is no nerve, it's a definite indication for a brainstem implant. But when there is a critical patient where the hypoplastic nerve or narrow internal acoustic meatus, which becomes very difficult for the radiologist to identify the presence of cochlear nerve among the seventh nerve and other nerve. Now, there are two things that we need to keep in mind. The first thing is check if the child has got some amount of residual hearing. Okay. See, if for example, severe to profound hearing loss is a range. It is not an absolute value. But if you look at the severe to profound hearing loss, if there is some amount of low frequency residual hearing, even if it is 90 decibels or 85 decibels or 100 decibels, that gives a very, very important information, because you can stimulate that frequency at a very higher level and see if you see any behavioral changes in the child, whether the child is hearing. If the child gives a consistent behavioral responses at a very high intensity of sound on the residual frequencies, then the nerve is present. Right. Now, this is number one, but I'm not asking you to make a decision based on it. This is number one to note. Number two, stimulate that particular frequency at amplified level, see if you can record a cortical potential. Because when the nerve is weak or nerve is stiff, it is very difficult to record an auditory brainstem response, because auditory brainstem response is a test of neural synchrony. It is not a test of direct neural conduction. But for a cortical response, you don't need super synchrony, is not required. Right? Though it may require some synchrony, but it does not require such an integral synchrony like ABR. So if you can measure a cortical potential in that particular frequency, that gives an important information that the nerve is conducting. This is number two. Number three is do a transtympanic ABR, do a promontory stimulation ABR. Now, instead of stimulating acoustically, you put an electrode on the promontory or round window niche, or the medal has got a new system called the auditory nerve testing system, where you can place the electrode on the cochlea, stimulate it electrically, and record the responses of the brainstem using EABR, called electrically evoked auditory brainstem response, by stimulating the promontory or the window niche. If you get a good response, then these are the indications that will tell you whether to go for a cochlear implant or a brainstem. Right? That is number one. And also it will give you an information about whether to choose the right ear or left ear for the surgery. Okay. And number one, see, these are straightforward responses. But in case, if you don't get a response in these conditions, you get a behavioral, but you're not getting EABR. You get a behavioral particle, but you're not getting an EABR. Then again, these two tests indicates, then we have to take a chance, and always the first choice of treatment should be cochlear implant. But if you don't get responses in any of these three tests, then definitely go for a brainstem implant. This is the protocol that we follow in our center to make a decision. But though we decide to go for a cochlear implant as a first choice of treatment in this case, you still have to counsel the patient regarding the limited benefits and extended rehabilitation. This is very important, because it's very difficult to predict outcome in these cases.
We are audiologists, but surgical stage of ABR is interesting for us as well. Probably you were on operations many times. Could you tell us about it, please, especially about audiological support of the operation?
Very important question, because especially when you do a brainstem implant, okay. Now the role of audiologist is to give a feedback to the surgeon whether the placement of the electrode is exactly on the cochlear nucleus. Because if the electrode is sitting on the cochlear nucleus, the patient will hear sound. If the electrode is not on the cochlear nucleus, the patient will have non-auditory sensation. It is not sound. So based on our data, and also from data from the literature, it's very clear when more number of electrodes are stimulating the cochlear nucleus, the outcomes are much better. So it is our duty to make sure more number of electrodes are sitting on the cochlear nucleus. But this will not be possible without an audiologist, because a surgeon will never be able to see the cochlear nucleus during the surgery. So he will not be able to know whether the electrode is on the cochlear nucleus or not. So you will have to do an intraoperative measures, intraoperative monitoring has to be done. Now, what is more important there is, the audiologist becomes a decision maker. The responsibility is on the shoulders of the audiologist. So he is the one who's going to tell whether the electrode position is correct placement or a wrong placement. If the audiologist makes a mistake, the future of the child is gone. So the responsibility lies on you. So it puts you a lot of immense pressure that you're very, very, very precise in your measurements. You're very, very good in your diagnosis. And also make sure that the decision what we make at that point of time is the decision for the destiny of the child with respect to auditory. So this is a great responsibility. And what is more important is the team that supports you, the surgeon, the neurosurgeon, the ENT surgeon, the anesthetist. They're all very, very important. You need to have a very, very good cooperative team to understand you. Because sometimes in some patients, it only takes 30 minutes for me to finish the intraoperative measures. In some other difficult cases, it almost takes even 3 hours for me to finish the intraoperative procedure. So the surgeon has to be cooperative, the team has to be cooperative. But at the end of the day, what is more important is you really feel that you're responsible at that point of time. And you are the one who's going to make a decision whether even to abort the surgery, it is your call at that time. For example, if none of the electrode is giving any kind of sensation, then what are we going to do? Are we going to continue the surgery and leave the electrode where it is, or do we abort the surgery and do it? So every call depends on your decision, your data. So it's a very, very unique feeling being there to make a decision for the rest of the life of the child.
Which approaches do you use during the first activation of ABR?
Well, in ABI, there are 2 things that we need to clarify as an audiologist. The first thing is, we need to know whether this electrode is stimulating the auditory nucleus or non-auditory area. So first, I have to classify which electrode is an auditory electrode, which electrode is a non-auditory electrode. That's the first thing I want to do. The second thing, after I classify which is auditory, which is non-auditory, then I'll have to set the stimulation boundaries, the threshold levels or comfort levels I have to set. Now, to set the threshold level and the comfort level, now there could be 2 methods. One is behavioral method, where you increase the stimulus and see the response of the child. And you can also do some loudness scaling. That depends upon the cognitive development of the child. If the child is cognitively developed, where the child can understand the loudness scaling game, then you can use that particular method to identify the boundaries of stimulation. If the child is too young and if the child has difficulty to identify, then of course you will also look at behavioral. And I'll also correlate with some amount of objective measures, right? What level to stimulate. But to be very honest, I'm not in favor of choosing the M levels based on the objective measures in ABI, because we don't have enough evidences as of now for that. We have very limited data on it. But I would combine both and predominantly depend on the behavioral. But I'll go step by step. So which means I will not be able to achieve the optimal level of stimulation in the first 1, 2, or 3 programming sessions. Like in cochlear implants, within 3 to 4 sessions, you can achieve optimal level of stimulation. But in brainstem implant, it's not possible. You may need extra sessions to do it, but that's how it has to be at the point. So you go step by step, slowly, and it will take at least 5 months to 6 months for me to achieve an optimal level of stimulation for that particular child. Whereas in cochlear implant, we'll be able to achieve it in a month or so. So this is the difference. But the first thing is identify auditory, non-auditory. The second thing is identify the stimulation boundaries in the auditory electrodes.
Let's talk about objective measurements with ABI. Which capture on EABR we will have, and does it really help in the fitting process?
Well, EABR is a very important tool to identify auditory and non-auditory electrode for sure. It helps in the identification of auditory and non-auditory, which helps a lot, which is very, very important for us during the fitting process. Even some of our studies, we have classified the morphology of EABR based on the latency and the amplitude of the peaks that we get when we measure. So based on that, we have classified auditory peaks and non-auditory peaks. Based on that classification, we will be able to identify which electrode is auditory, which electrode is non-auditory, which electrode is mixed. Mixed means this electrode will stimulate both auditory and non-auditory. Okay. So EABR helps in a great way to identify the first step, which is auditory, non-auditory. The second thing, to identify the optimal stimulation boundaries for each electrode, EABR helps us, but I wouldn't say I can trust EABR completely on that. It's very difficult for me to do it at that point of time. But I would use the data from the EABR and also combine with the behavioral measures. And then I'll come to a decision on that. So, but I'm not trying to tell EABR is not a tool to identify the stimulation boundaries. We don't have enough data, confirmatory data, that, okay, this is the value or the threshold of EABR. So I would set the stimulation parameter based on that, like how you correlate with your ECAP and stimulation levels in cochlear implant. That correlation we have not achieved with EABR and brainstem implant. So I would take the EABR data, combine with the behavioral, and set those levels. But definitely EABR plays a major role.
Ranjit, is it possible to get electrically evoked medial latency responses and electrically evoked corticals with ABI? Are they commonly used in the practice?
Now, if you ask me, is it possible? It should be possible. But if you ask me, I have done it. No, I have not done it yet. I have not done EMLRs or E-cortical responses in ABI. But what we have done is we have done aided cortical responses in ABI. That was possible. And we've even correlated the aided cortical responses with respect to the maturation of the auditory cortex. That is possible. And we've also done FNIRS in ABI. FNIRS is functional infrared near field spectroscopy. We have done FNIRS in patients with ABI. That is very much possible. Now, the third thing, what we are doing currently is ECAP, electrically evoked compound action potentials in ABI. Now, there are very, very limited data which is available in the literature. One of the recent publications was published in Hanover Center in the year 2021, if I'm not wrong. There, they could measure the compound action potential just because it is very difficult for them to identify whether it's with cochlear nucleus or some other neurons. They've termed it as a local evoked potentials, which is very important. So what we are doing is we are developing a novel algorithm, which will help us to measure compound action potentials. Based on the measures of the compound action potentials, we will be able to do intraoperatively help the surgeon to identify the correct location of the cochlear nucleus. It will also help us to identify whether the electrode is an auditory or non-auditory electrode. And it will also in the future will help us to map the boundaries of stimulation. And this data combined with EABR, combined with behavioral, will give us more information on the measures. But to answer your question, electrically evoked MLR, electrically evoked cortical potential are possible, but we have not done it. But we have done acoustically evoked cortical responses in ABI, FNIRS in ABI, and ECAP in ABI.
Is it reasonable to perform bilateral ABI or ABI on one side and CI on other side? Is it common practice or not?
No, it is not a common practice, but you can go on a case-by-case basis. Now, of course, to make a decision for bilateral ABI, to make a decision for ABA and CI, it's a little complicated. There's a lot of factors come into play. Funding is one of the major factors in that. And also ability of the family to sustain two devices or offer maintain two devices also becomes an important question. So it is definitely not a common practice, but it is a case-by-case basis. But if you ask me if any of our series have got bilateral ABIs or ABA and CA on one side, no, so far no. But we have done ABIs on one side. And due to some complications, we removed the ABI and we did the ABI on the contralateral side. So that we have done, but we don't have bilateral ABIs at the moment in our series.
Is it necessary to involve speech-language pathologists in the fitting process of ABI?
Definitely yes, because speech-language pathologists are very, very much important. Now, I would add one more thing, speech-language pathologists and also auditory rehabilitationists. Both of them are equally important. You may also need an occupational therapist or a physical therapist because some of the children with auditory brain implant also have additional disabilities which needs a holistic approach for rehabilitation. So speech language pathologist role is very, very, very important. And most importantly, all these three professionals also understand what audiologist wants, and audiologist also understands what they want. So it is a combined interactive team networking, which is very, very important to maximize the benefit for the child.
Are there any differences in rehabilitation of patients after ABI comparing with patients after CI? How outcomes of ABI can be described? What they depend on?
There's a lot of difference in terms of rehabilitation. The first thing is the duration of rehabilitation. Because if you look at our data, the outcomes with ABI gradually improves for the first 24 months. And after 24 months, it is slowing down, plateauing down. Okay. Now, which means there are a lot of things that we can discuss about it, but one of the commonest thing is the practice that we have in India is in our center is after the ABI, it is mandatory for them to undergo rehabilitation for the first 2 years. Right? So the scores improve. After 2 years, there is no mandate for them to continue rehabilitation because people are from different parts of the country. They go back to the town. I don't know. Sometimes they don't follow rehabilitation over there. So the outcome is slowing down. But in cochlear implant, it is different. In cochlear implant, the first 1.5 years of rehabilitation is very important, after which the child improves gradually over a period of time. But in a brainstem implant, it doesn't happen like that. Now, the reason could be the way we stimulate the brainstem is different from the way we stimulate the cochlea. More higher you go in stimulation, more complicated it is. So the coding strategies that we use in cochlear implant is exactly the same strategy we also use in brainstem implant. But the way the signal coded in the cochlear nucleus and the cochlea are different. So there are n number of reasons that we can give why the outcomes in brainstem implantees are poorer compared to cochlear implant. There are a lot of reasons to it. Now, another important reason is the stimulation that we give on a cochlear nucleus is not stimulating the entire cochlear nucleus. Whereas when you stimulate the cochlea, it stimulates the entire cochlea. So all the neurons, the nerve takes all the information to the cochlear nucleus when you stimulate the cochlear implant. But when you bypass the cochlea, when you bypass the cochlear nerve and stimulate the cochlear nucleus, you're not stimulating the entire cochlear nucleus. So there are n number of reasons. Plus the children also have additional disability. So the outcomes in brainstem implant is poorer to cochlear implant. The rehabilitation has to be much longer. The rehabilitation team is much wider because you need a speech language pathologist, occupational therapist, auditory rehabilitationist, physical therapist. You need a psychologist and also a parent and audiologist. They have to work for a longer time, which means the rehabilitation in a brainstem implant, in my opinion, should not be less than 4 years. Minimum of 4 years of rehabilitation is mandated based on our experience. And predicting the outcomes of brainstem implant is very, very difficult. One of the factor as of now which correlates very well with the outcome is the presence of EABR in more number of electrodes. For example, if there are 12 electrodes in a brainstem implant, if 75% of the electrodes are giving good EABR response, that means more than 9 electrodes are giving EABR responses, the outcomes are much better. This is the only key that we've got to predict the outcomes in ABI. So predicting outcomes in ABI is a little difficult. The rehabilitation has to be much longer. The rehabilitation team has to be bigger and experienced.
One more difficult situation, postsynaptic auditory neuropathy spectrum disorder with low or no effect of cochlear implantation. How do you think, would ABI technology be more successful as a second-line strategy?
It's one of the most complicated things to answer because the decision to do a brainstem implant is only when the cochlear implant is not giving any benefit. So the first choice of treatment with auditory neuropathy spectrum disorder should be a cochlear implant, number one. The cochlear implant combined with other strategies, for example, cochlear implant with an AFM technology. Okay. So we have to try all the permutation combinations before we decide to switch over from cochlear implant to a brainstem implant. Now, in my opinion, the post-synaptic auditory neuropathy itself is a little dicey thing. Now, for a patient who's been diagnosed with bilateral to profound hearing loss, and what is the indication for you to confirm it is a definite post-synaptic neuropathy? Okay, so the pre-implant investigation plays a major role in decision making. And what do we do if there is some amount of residual hearing? The first thing, apart from your classical indicators for ANSE, like absent ABR, absent acoustic reflex, presence of OEE, apart from that, our protocol, we also do LLRs or cortical potentials to see the presence of it. We look at the morphology and latency of the cortical potentials if present. The second thing, we also do transtympanic EABR if cortical potentials are absent. We will not do transtympanic EABR when the cortical potential is present, because we will not stimulate the cochlea electrically unnecessarily. We will have to do it. When the hearing loss is severely profound, and when the cortical potentials are absent or it's difficult for you to measure acoustically, then you go for a transtympanic EABR. Okay. Before going for all those things, we do a hearing aid trial. Along with the hearing aid trial, we also give a FM trial, assistive listening device. The hearing aid is combined with an assistive listening device, and we try to see how much benefit is getting an assistive listening device. So with all the information from all these investigations, then you come to a decision making whether this patient needs a cochlear implant or not. We don't even discuss about brainstem implant at that point in time. And once we decide for a cochlear implant, then we also counsel the patient regarding the benefits post-operative cochlear implant outcomes, specifically talking about the variability in outcomes and the importance of training. Now, after cochlear implant, with very good follow-up training, if the patient is not getting any benefit, and if the score prior to the cochlear implant and after the cochlear implant is not much different, then we can initiate a discussion about brainstem implant. Now, again, what is uncertainty here? Nobody knows how much the benefit will be after brainstem implant, because we can't predict the benefit. If the patient is willing to take a chance for a brainstem implant, then we go ahead with the brainstem implant. But what is the chance is the cost. If the patient, so there is a possibility the patient may benefit, may not benefit. The outcomes may be similar with cochlear implant, or it may be better with the brainstem implant. We don't know. The brainstem implant benefit can be as good as cochlear implant, or better or worse. Anything is possible. If the patient is willing to take the chance, then we go ahead with the brainstem implant, because we have to do all permutation combinations before we come to a decision. Because to answer in one line, we never recommend a brainstem implant for any patient diagnosed with any type of auditory neuropathy spectrum disorder.
Is there an experience with ABI in patients with central auditory processing disorders?
Now, to answer this question, the first indication for a central auditory processing disorder itself is normal hearing. So if there is a patient with a peripheral hearing loss, it is very difficult for us to diagnose whether the patient has got a central auditory processing disorder. When a patient has got a normal hearing, then it's not an indication for a brainstem implant, a cochlear implant, or a brainstem implant either. So central auditory processing disorder is a very dicey terminology, which means, in my opinion, there are a lot of processing happening in the auditory system. There could be a lot of disorders in the processing. Any disorder in the processing is termed as central auditory processing disorder. However, there are different types of processing that happens. For example, detection, discrimination, memory retrieval, foreground, background, figure retrieval. So a lot of processes happens for us to identify, detect, discriminate, and comprehend a specific sound or a speech. Okay, so this is called processing disorder. So the fundamentally processing disorder is you can only diagnose processing disorder when there is a peripheral hearing is normal. So definitely they're not a candidate for any kind of interventional processes in this case.
Definitely, there is a group of patients who have contraindications both for CI and ABI. What management strategies would you recommend for them?
Well, now the only management strategy for them is a total communication. Now we need to see the ultimate goal of giving a cochlear implant or a brainstem implant, despite knowing the outcomes are variable, is because to provide some sort of sensation to the auditory cortex, so that the brain will make use of even a very minimal information to maximize the learning capacity. That's the idea of giving some sort of input. For example, even if you take patients with cochlear implants or a brainstem implant, there is a variability among etiology. There is a variability among candidates, right? So not all patients are going to perform at the same level. But despite that, why do we still provide brainstem implant? Simply because we are giving the opportunity for the brain. We're giving added information to the brain, which will maximize the learning capacity. Okay. Now, I will give you one small example. When we did the first brainstem implant, that was in the year 2009, we didn't have any great experience. We didn't have a big experience with pediatric at all, no experience. So I had limited chance to identify auditory and non-auditory electrodes. Now later, after 1.5 years, I purchased a new device called the cortical potential device, and I started measuring the cortical potentials in this ABI. Now, for a simple fact that I will stimulate each and every electrode and see if I could measure a cortical response. Now, to my surprise, there are few electrodes which did not give any cortical responses compared to other electrodes. So, which confirms these electrodes are non-auditory electrodes. When an electrode A or electrode 1 can give a cortical response, and electrode 2 does not give a cortical response, it has something to do with it. So, we assumed these are the non-auditory electrodes. And we also tested behaviorally, because the child is almost old enough to give consistent responses. The behavioral responses also confirmed these electrodes are not auditory. Okay. Now, what I did immediately, I switched off those non-auditory electrodes. Now, you know what happened after I switched off? The child did not like it. So, the non-auditory sensation is perceived as auditory sensation for a student. So, which means that the brain is doing a cross-modal learning. The cross-modal plasticity is happening for this child. So, how the brain makes use of the information is a big topic to discuss. So, keeping all those factors in mind, right, to answer your question very specifically, it is very, very difficult to to make a decision in these kind of situations. But we'll have to go case by case with enough evidences.
And my last question for you, what's your prediction about further progress in hearing implants? Can we expect the inferior colliculus implant or even coccygeal implants in the future? What do you think?
Now, well, I have a different perspective on it. Yes, you can expect a cortical implant, you can expect the inferior colliculus implant. That is not difficult, but what is more important is how are we going to code signals to cochlear nucleus? How are we going to code signals to the cortical cortex? So they are completely different, right? So unless we understand how we code informations, right? It's not, I would say it will give some kind of sensation to them, but we wouldn't be able to come to a level where we can maximize the benefit in those cases. But rather, looking at cochlear implant itself needs a lot of changes in terms of signal coding. The way we've been coding signals in cochlear implant, in the last 20 years, there was no change in it. In the last 20 years, the way we code signal is almost the same, which means there's no great development has happened in that area. Right? I think we should focus on that first. So now we need to develop the strategies or methods where we can give precise coding of information. that is restoring better temporal integrity is very important. The biggest lack in a cochlear implant is restoring temporal integrity. So that is why the music perception, speech perception, and noise is still a challenge for many people. Right. So this is something which we need to focus on. For example, there have been a lot of research which is going on optical stimulation of cochlea, to genetics, all those things. I think these are something which is very, very important for me, that rather than looking at the stimulation site, it is more important stimulation site plus the stimulation technique to maximize the benefit is more important. So we have to go in that direction to see how we can improve the quality of sound with cochlear implant. Undoubtedly, hearing implants has made a lot of change in the lives of millions and millions of children and persons with hearing impairment, no doubt about it. But yeah, we should be proud of what has been happened in the field, but we should never, feel so elated, or we should never take a relaxed seat as we have achieved it. No, if you compare normal hearing, the qualities of normal hearing, the abilities of normal hearing, bilateral normal hearing, and the abilities with the cochlear implant, there is a lot of difference. I think we should see how we can bridge that gap with the technology. That is the future that we need to look at first step. The second step, obviously, cochlear middle-ear implants, mid-brain implants or cortical implants. Of course, yes, it has to develop along with better coding methods and better evaluating procedures. This should be the future.
Dear Ranjit, this talk was extremely interesting for me, and I'm sure that my colleagues will agree with me. Thank you for that.
Thank you very much, Mrs. And give my wishes to all your colleagues. And let's all work together to improve the quality of life for children and adults with hearing and communication disorders. Any help of any sort, you or your colleagues are always most welcome to reach me. Thank you very much.
Thank you.